Okay, so this is the last of the series on diabetes, and it's going to be on hyperglycemia or diabetic ketoacidosis and how we treat that. And so with this screen, let's just refresh our memories on the pathophysiology. I remember the beta cells have been wiped out or destroyed. The person does not produce enough insulin, so they have an insulin deficiency, and so the body cannot use sugar for energy. And so sugar is going to build up in the blood and also into the urine. And if you look over here on the left side, you can see that the body can't metabolize the glucose. Sugar builds up. It leads to an osmotic diuresis. Um, so remember where osmosis says water goes from a low concentration to high concentration. So the water dumps into the blood vessels. So those blood vessels go through the kidneys. They're going to pee out all that extra fluid. So they'll have sugar in the urine, they'll have polyuria, they're peeing out all the fluids, and they're going to lose a lot of fluid and electrolytes here, and so they'll become dehydrated, and they'll become hypovolemic, and it could lead to shock and death. Now that's because they can't utilize the sugar. Now the other two energy stores that your body will use for sugar would be fats or proteins. And so if we look over here on the right side, you can see that when the body breaks down proteins, there's going to be amino acids that are going to be used up and broken down, used for energy. It leads to a negative nitrogen balance or muscle wasting, and that can lead to shock and death also. You can see right here in the middle, if you see my cursor, the body will also break down fats. And as the body breaks down fats, it's going to lead to ketone formation. Ketones are highly acidic, and it leads to ketoacidosis, and this will also lead to electrolyte imbalance and coma and death. And so that's the pathophysiology for diabetic ketoacidosis. This slide talks about the same thing, that in hyperglycemia, what's it caused by? And it's either too much food, not enough insulin. The onset is usually gradual. The blood sugar is going to be greater than the 110, which is normal, and often it's up around 2, 3, 4, up to 7, 800. It can be really high. And what can we do? Well, because the blood sugar is high, we need to give that person insulin. And because they're dehydrated, we're going to have to give them fluids, but we'll see that on the next screen. Some of the signs and symptoms, because they have the polyuria, they're going to be thirsty, and so they're going to drink a lot, and they're going to have the dry skin, hunger, nausea, drowsiness, blurred vision. And remember the little saying that we use for hyperglycemia is hot and dry, sugar's high, or like one of my colleagues says, dry and hot, they need an insulin shot. Okay, now you're going to get this when you go on to third and fourth semester, so I'm not going to spend a whole lot of time on this section. You'll get it then from the instructor that teaches third and fourth semester, but I just want to highlight some of the common principles here for hyperglycemia or diabetic ketoacidosis. So remember, they can't use sugar, and so they're going to be peeing out all kinds of fluids, so they'll be dehydrated. They'll have that fruity odor on their breath. Remember, their body's trying to get rid of the ketones, which are highly acidic, and so they're going to have that acetone smell to their breath. They're going to have the Kussmaul respirations, rapid deep respirations. They're going to be hypotensive because they're dehydrated. They're peeing out their fluids. They'll have decreased level of consciousness. We talked about the polyuria before, tachycardia, thirst. They'll have warm, dry skin, and that's where we get that little statement, hot and dry, sugar's high. They'll be lethargic and weak. And like it says there, their blood sugar level is going to be, well above the 110. So from 250 to 800, it says here. Now, to diagnose diabetic ketoacidosis, and you'll get this in fourth semester. You don't need to know it here in first semester, but they're going to be, they call it ketoacidosis. And so remember when we learned about acid-base balance, Acidosis means that the pH is less than 7.35, and so that's what they're going to have here. They're going to have a arterial pH, less than 7.35. The anion gap is going to be greater than 12, and often it's greater than 14. But you'll get that later in third and fourth semester. They're going to be spilling ketones because they're breaking down fats for energy, and they're also going to have hyperglycemia. And then the last one there, like I just mentioned, is hyperglycemia, and it's going to be usually pretty high. Now, I'm not so concerned that you know that. On your test here in first semester, what I want you to know is that because the person's peeing a lot and they're dehydrated, this person needs fluids. And because they're peeing out all their fluids and electrolytes, that's what we have to replace is fluid and electrolytes. And because they're hyperglycemic, what we need to do is give that person insulin. And so that's what you're going to see for the treatment here. We want to administer fluids and electrolytes to correct the fluid and electrolyte imbalance. Often it's going to be an IV of normal saline. We don't want to give them any IVs that have dextrose in them because their blood sugar is already high. And so usually normal saline is the most common one that we're going to give. And if they have any electrolyte imbalances, we want to correct that. And then we also want to start an infusion of insulin. And most commonly, the doctor is going to write an order for regular insulin through the IV. And the doctor is going to write titration orders. Often the order is going to say start at 5 to 10 units per hour. At the bedside, what we would do is we would take a 100 milliliter bag of normal saline, we'd dump 100 units of insulin in there, and we would have a bag of regular insulin that had a concentration of 1 unit per milliliter. And so when the doctor would write an order, give 5 to 10 units per hour, then let's say we wanted to start at 10 units per hour, then we just started at 10 milliliters per hour, and then we knew the patient was getting 10 units per hour. And as a nurse, what we want to do is monitor their blood sugar levels every 30 minutes to an hour. And then as the blood sugar begins to drop, let's say we get down close to the 250 range, then as a nurse, we're concerned about rebound hyperglycemia. And what we'll do is we'll start slowing the infusion rate of the insulin. What happens if we don't? Let's say we get down to 250, we're still giving them 10 units of insulin. Let's say they get down to 200, we're still giving them 10 units. They'll continue to drop. Let's say they get down to 110, we're still giving them 10 units. Well, now the problem is we can go the other direction and we can cause this person to become hypoglycemic, and we don't want that to happen. So just like I said, when the blood sugar gets down around the 250 range, we start slowing the infusion of regular insulin, maybe down to 5 units and maybe a little bit lower. And then we'll stop the insulin once they get back down to a normal blood sugar range. Okay, and then this I'm not going to test you on in first semester, but it's a kind of a neat way to know how to figure out if the person's in acidosis. If you're on a regular floor and you don't have ABGs, this is what a doctor will use to diagnose or assess for acidosis. And what they do is they look at the major cations inside the blood, which is sodium, and then from that they subtract the 2 major anions, which would be chloride and bicarbonate. And if the difference between the cations and anions is greater than 14, then it indicates or shows that the patient is in some type of acidosis, either a metabolic acidosis, a lactic acidosis, a ketoacidosis, or some form like that. And so this is called the anion gap. So if it's greater than 14, it shows that they have some type of acidosis going on, and the normal anion gap is between 8 and 14. So greater than 14 shows they have acidosis.